Thank you very much, gentlemen. And I'd like to ask Dr. Ellen Chadwick from the Lurie Children's Hospital and Northwestern to introduce our next speaker.
Thanks, Rich. It's my pleasure to introduce Dr. Deborah Persaud, who is Professor of Pediatrics in the Division of Infectious Diseases at the Bloomberg School of Public Health, with an appointment in molecular microbiology and immunology. She is one of the earliest investigators in the field of HIV reservoirs and was the first to develop a method to be able to study this in very small blood volumes, enabling this to be investigated in infants and children. And this was first published in 2000. And since that time, she's expanded our knowledge with more than 35 publications on this subject. She has led the CURE committee at the Impact Network and led the CURE agenda as the committee chair. And today we'll speak about sustained remission of HIV after early ART in an infant, AKA the Mississippi baby. Deborah?
Good morning. Thank you, Ellen. Oh, I see it doesn't show on the screen here. So I'm going to go over some key concepts that Rich covered earlier, but just to provide the context for the Mississippi baby. So there, with respect to CURE and its definition, it's really sustained control of virus replication to clinically undetectable levels in the absence of antiretroviral treatment. And there are two general broad categories, as Rich mentioned. There's what's defined as functional cure, and the second, sterilizing cure. And the main differences between these two definitions is that with functional cure, an HIV-infected person is allowed to have detectable replication-competent reservoirs, but there are some host immune mechanisms or host factors that maintain control of virus replication to clinically undetectable levels. Now, one example of this is elite controllers who have specialized HLA alleles that allow them to develop HIV-specific CTL responses that keep the virus in check. With respect to sterilizing cure, as Mr. Brown, and I'm really honored to be in the same room and hopefully to be able to meet Mr. Brown later in the day, is really the only individual who's demonstrated sterilizing cure of HIV. And in his situation, there's really no detectable replication-competent reservoir that has been identified to date 7 years post-transplantation. Now, studies using ultrasensitive methods intermittently detect HIV nucleic acid in the blood of Mr. Brown, but it's unclear to what extent those are clinically relevant or represent assay variation. So obviously with both conditions, sterilizing and functional cure, it's not only important to have virologic control without antiretroviral drugs, but the individual needs to be able to maintain CD4 levels to the normal amounts, and in addition need to have no ongoing evidence of immune activation, which is really the issue we're dealing with heart in terms of the long-term consequences of having ongoing immune activation, and obviously to not be able to transmit the virus to susceptible persons. So with respect to the Mississippi child and pediatric HIV infection, we've coined the term remission because obviously to be able to declare someone as being having functional cure or sterilizing cure, you need to have some window of observation to be able to say, okay, this person is able to have sustained control of virus replication. So for pediatrics and for our clinical trials going forward, which Chadwick is the co-chair of very early treatment in infants to assess cure, the definition we're using is really an infant with documented infection, and I'll go through how we identify infants as being infected and their management. But in other words, an infant with clear documented infection who's received an intervention, and in the case of the Mississippi child, it was very early antiretroviral treatment. And what we mean by very early antiretroviral treatment is really treatment initiated within the first 48 hours of life. We're not quite sure what that window of opportunity is, whether it's 24 hours, 48 hours, or maybe up to a week, and clearly it will be important to identify what that window of opportunity is. But very early treatment is really within the first few days of life, compared with early treatment, which is generally 2 to 3 months of life, which is what we've had most of the experience with. And so this duration of suppression or control needs to be within 12 months or more. And certainly to be able to maintain normal CD4 levels, not have evidence of immune activation, and may or may not have detectable HIV-specific immune responses. We know most HIV-infected children who are treated early, that is about 2 to 3 months of age, if they've controlled virus replication by a year of age, they really lack evidence of HIV exposure when you look for HIV-specific antibodies or CTLs. And they also have very low levels of proviral DNA present in the peripheral blood. And obviously to have a lack of replication-competent HIV reservoirs. They may or may not have detectable HIV DNA. And so just to kind of briefly go over the pediatric AIDS epidemic, while in this country there's been significant progress in prevention of mother-to-child transmission. Our transmission rates now are less than 2% compared to 30 to 40% in the days when we didn't know how to prevent mother-to-child transmission through use of antiretroviral drugs. Nevertheless, globally, this is a big problem, and you know, there are 3.3 million children living with HIV, so it's important to keep an HIV cure agenda on par with the adult studies that are ongoing. And you know, there's still over 260,000 new infections in infants in 2012. Now, this number, it reflects progress. There's been a 52% decline globally in new infections in pediatrics, but it's clearly not an acceptable number. And even in the United States, you know, we have 150 to 180 infants born each year with HIV infection. And so, you know, that's 150 too many infected infants in this country. So again, emphasizing the need for interventions aiming at cure for this population, and then significant number of deaths. Now, how do kids get infected? And this is really the low-hanging fruit for pediatrics with respect to a cured agenda. We know when kids are exposed to HIV. It's during pregnancy, during labor and delivery, and postpartum through breastfeeding. Now, in the United States, breastfeeding is avoided in women who are HIV infected because of the safe and affordability of formula feeding. But in most resource-poor settings, breastfeeding is standard of care because it is life-saving for these infants. So what you see on this slide is the overall risk of transmission based on timing of infection in the absence of antiretroviral treatment and interventions. And so by the fact that we know when infants are infected, we know the relative risk of transmission, we can actually develop treatment strategies in terms of very early therapy and have a balance in terms of risk-benefits of these approaches. And so what you see overall, intrapartum infection, which is during the time of delivery, it's quite a bloody procedure, it's about 10 to 20%. There's a lot of exchange of maternal blood into the fetal circulation. In utero, about 5 to 10%, and by breastfeeding, 5 to 10%. But overall, with antiretroviral drugs, we can drop these transmission rates to under 2%. Now, what is standard of care for prevention? So all HIV-exposed infants receive post-exposure prophylaxis with antiretroviral drugs. And the mainstay of prophylaxis is zidovudine. And zidovudine is given for 6 weeks to all HIV-exposed infants, irrespective of maternal treatment or suppression. Now, if a mother is well suppressed, the guidelines have now been changed that you can truncate that to 4 weeks. But there are a lot of caveats here, good suppression and adherence. The mainstay is really 6 weeks of zidovudine. Now, if a mother is high risk, so has not been identified as infected or has non-suppression of virus replication, then more than one drug is used. And this will have relevance for you when I describe the Mississippi child and the outcome in that child. So the standard now, and these guidelines were updated a couple of months ago, is really zidovudine with a second drug, nevirapine, which has a very long half-life, penetrates well into central nervous system, crosses the placenta very efficiently. And in this setting, it's a 3-dose regimen given over the first week of life. Now, how do we know whether an HIV infant who's exposed is infected? It's important to point out that the antibody test just reflects exposure to the virus. It's an IgG antibody test, so it crosses the placenta, so antibody testing cannot be used to identify infection in an infant. And this becomes problematic in terms of identifying infection early in an infant. What is required to confirm infection? And as we talk about cure strategies, we're going to really need to pay attention to documenting that an infant really has been infected. We do know that some of these tests, because they're nucleic acid-based testing, can have false positive results. And so the mainstay of diagnosing infection is having 2 positive nucleic acid tests on 2 separate blood draws on 2 separate occasions. And so if an infant has 2 sequential positive tests, that infant is diagnosed as having infection. Diagnosis of infection in an infant, whether it be as early as 2 weeks of life, 4 weeks of life, or in the case of the Mississippi child, at 31 hours of life, then that means continuation of antiretroviral treatment for life. Now, as Rich pointed out, the main obstacle to virus eradication and cure is really the early establishment of reservoirs for HIV throughout the body of an infected individual, including the central nervous system. And the most well-studied reservoir for HIV is that shown on the bottom of the slide, right, the resting CD4 T cell latent reservoir compartment, which Rich described earlier. It's felt to be formed largely in the context of immunologic memory formation. These cells are designed to live for the lifetime of an individual through homeostatic proliferative mechanisms, so they can provide immunologic memory. And what you see within the resting memory CD4 T cells is HIV resides in a quiescent form. It's transcriptionally silent, and so it cannot be seen by immune surveillance mechanisms or cannot be targeted by our current antiretroviral drugs. These cells can be quantified in the peripheral blood of an infected person, and you can look at how much of these cells persist within an infected person as a function of time of treatment, duration of treatment, and age of treatment. And this is the landmark study from Bob Silcano's group showing up to 7 years of continuous antiretroviral treatment in HIV-infected adults. There's no decay of this reservoir in peripheral blood using a virus outgrowth assay over the time frame of treatment. And this led to the notion that HIV is really an incurable disease because these cells persist for the lifetime of the infected individual. But the tipping point really in HIV therapeutics is really the case of Mr. Timothy Brown, in which, as Rich described earlier, had intensive treatment for acute myelogenous leukemia, for which multiple factors probably led to sterilizing cure in Mr. Brown, as outlined on this slide, including intensive chemotherapeutic strategies, total body irradiation, and then transplantation with these specialized cells with CCR5 delta 32. And graft versus host disease. And this slide shows what heralds cure in an infected person. What you see in red is the plasma viral load of Mr. Timothy Brown on heart. When heart was interrupted, you see this prompt rebound in plasma viremia, shown by the red hatched line, with, again, spontaneous control when heart is re-implemented. And over the time course of treatment, what's noted is that with heart discontinuation, the dashed red line never increases. And so that's really what defined cure in Mr. Brown, is really the spontaneous control of virus replication in the absence of antiretroviral treatment. And using standard laboratory testing, it became difficult to detect proviral DNA within the peripheral blood cells. Now, importantly, using ultrasensitive tests, there remains trace amounts of nucleic acid present within the blood cells of Mr. Brown, as I said earlier, of which the clinical relevance is unknown. But what's critical here is that replication competent virus that is capable of refueling infection has not been detected on studies of millions of cells taken from his blood. And so with respect to perinatal HIV infection, since this reservoir is established in the context of immunologic memory, what you see on the far left is really memory T cell formation over the time frame of life as an infant switches from an intrauterine life to an extrauterine existence. And so most infants are born with naive cells, so they really don't have a memory T cell compartment that's established just yet. It actually takes 20 years to establish your full complement of memory CD4 positive T cells. And it may be this feature of neonatal infection where the process of development of immunologic memory is quite slow, that may provide an added opportunity for very early treatment to curtail these reservoirs from forming in the context of very early treatment. In addition, the neonatal immune system has very low levels of CCR5 expressing CD4 T cells. It takes about 5 years for those to really get to adult levels. And the neonatal immune system is really skewed towards innate immune responses rather than adaptive immune responses, which is required for establishment of this reservoir. So together, we believe that very early treatment in the context of a neonatal immune system may have afforded the outcome in the Mississippi child. And so this is our working model with respect to establishment of this latent reservoir, and this is one reservoir. There are other reservoirs that have not been fully identified because they're just difficult to access with respect to the central nervous system and tissue reservoirs. So what you see on this slide is really our working model for establishment of this reservoir. On the far right are what you would expect in the absence of no antiretroviral treatment in HIV-infected children, And on the far left, with immediate therapy, we can really restrict the resting memory CD4 T cell reservoir from forming in blue. And indeed, our studies in children looking at chronic infection, meaning they started therapy at about 8 years of age, we see the same pattern of persistence at 5 to 6 years on heart as seen in adults, with a median frequency of 1 per million. More recently, we've identified that adolescents treated early at 2 to 3 months of age actually appear to have a contracting reservoir at about 14 to 18 years of age, a finding that really warrants further investigation. So this is the study showing that this similar pattern of stable persistence of this reservoir in the context of chronic treatment in children. Now, what you see on this slide is really the classic biphasic decay. So this is the standard plasma viral load plot of an HIV-infected infant starting therapy at about 2 months of age. And what you see is this classic biphasic decay in plasma viremia that Rich described earlier, representing infection of 2 different populations, acutely infected activated CD4 T cells to turnover at about a day, and then followed by the second slower phase decay of cells with longer half-lives of 14 days or so, such as macrophages, followed by continuous suppression. And in some kids, you can detect what's referred to as blips or intercurrent viremia that does not preclude failure of the regimen. So in other words, early therapy at 2 to 3 months of age can lead to sustained control of virus replication in perinatal infection, as seen in HIV-infected adults. And so we were interested in terms of the extent to which this reservoir is established in infants who receive therapy at 2 to 3 months of age. And these are data we collected in the P1030 trial, of which Ellen Chadwick was the protocol chair, and really has become the signature slide to form the reference for the Mississippi child. And this is why we recognize the Mississippi child as being different, as I'll describe later, is that from these studies we learned very quickly that even infants treated as early as 6 weeks of age or before 6 weeks of age, shown in red, while the reservoir was restricted in those infants, it was still present. At about 6 months of age, we could detect it, and again through 96 weeks of age. And so what we learned from this is that 2 months of starting therapy at about 2 months of age is too late with respect to aborting reservoir formation in terms of it having clinical relevance to refuel rebound viremia. And this is exactly what we see in pediatric HIV infection as seen in adults, is despite early effective treatment with non-adherence, there's rebound in plasma virus to pre-treatment levels shown in blue. Now, with respect to the Mississippi child, we first presented this at CROI in 2013 when the child was 28 months of age. And what you see on this slide is her pediatrician, Dr. Hannah Gay, who was really the one who spearheaded this project and realized that this child was distinct from any other pediatric case she had managed in her practice, and for which she called us to collaborate with her to investigate why this outcome in this child. And so this was a child who was 28 months of age when she presented as having had a diagnosis of HIV infection based on under the care of Dr. Hannah Gay, was on treatment for 18 months, as I'll describe later, went off treatment and then failed to have rebound in viremia. So the child was born at 35 weeks gestation, normal spontaneous vaginal delivery. And what was different about this case, the mother's diagnosis was identified during labor and delivery by a rapid test. And so in that setting, this is someone who's not engaged in prenatal care. This would be considered a high-risk infant who would get more than AZT for prophylaxis. So in this setting, what was done is AZT, 3TC, and nevirapine, which is a treatment regimen really in perinatal infection. But what was different here, instead of the 3-dose regimen of 3 doses given over a week, this child was dosed at therapeutic dosing levels, or what we believe to be therapeutic dosing levels of twice daily dosing on a daily regimen twice a day. And so obviously with a rapid test, you empirically start infants on prophylaxis, but then you have to confirm that the mother is infected, and indeed this mother was infected by ELISA, by viral load, and it was infection with HIV-1, and it was subtype B infection. The mother's viral load was fairly low, 2,400 copies per ml, but still sufficient for transmission of infection to the infant. Infant infection, as I said earlier, what's required for confirmation of infection, and there's been much controversy in the field as to whether this baby was infected or not, is what you see here on this slide is this infant had 2 independent nucleic acid tests that were positive, a DNA test and an RNA test. The viral load was about 20,000 copies per ml. And again, while this is on the low side for infants who are infected in utero, it's still within the range of infection, within the range of the levels we see in utero infection. So clearly confirmed infection. Again, further confirmation of infection, not only in short-lived cells, but more intermediate-lived cells. You see the classic biphasic decay in plasmaviremia that's reflective of turnover of infected cells with different lifespans. And here we had multiple detectable plasma HIV RNA levels in this child, again supporting infection and establishment in different cell populations. Now, here's what really heralded remission in this child. As you see at 18 months of age, with the purple arrow, the child was last seen and lost to follow-up and then returned to care at 23 months of age. And at that time, there was the report of ART cessation. And you can see that repeated viral load measurements remained undetectable, so no rebound in plasmaviremia. In addition, the HIV antibody tests were negative, and the HIV DNA test that was done to initially diagnose infection in this infant came back as negative. And this was when we were called to evaluate this child. Now we've done, and I'll show you later, extensive ultrasensitive testing on this infant looking for HIV infection. But this is what's heralding remission in this child. You could see 23 months off antiretroviral treatment. The Mississippi child remains with virologic control to clinically undetectable levels of antiretroviral treatment. Now, importantly, the CD4 T cells have remained normal for age through follow-up, which again is an important component of saying someone is in remission. And what you see on this slide are the multiple ultrasensitive testing using single copy viral load assays, the virus outgrowth assay on enriched CD4 positive T cells, and we failed to detect replication competent virus in this infant. And most of the ultrasensitive viral load assays, except for one, have remained undetectable. Now, what's curious about the Mississippi baby is on sequential follow-up, we continue to detect proviral DNA in the peripheral blood of this child. Now, what's shown in red is the samples. We test multiple samples from different cell fractions, showing persistent detection of proviral DNA. These levels are fairly low. It's really at the limits of detection of these assays, and it's hard to know whether it's noise from the assay or a true signal. But I will say, cumulatively, the fact that on every visit on multiple cell types, we continue to detect proviral DNA. And we've gone to actually convince ourselves that the DNA tested on this infant, that the samples really belong to this infant by doing HLA testing, and all of the samples are HLA identical. So there is some evidence, we believe, of a genetic imprint of the virus in this child, but the clinical relevance is unclear as it's not replication competent. Looking in terms of immune factors that may have contributed to virologic control following very, very early treatment in this infant, we're unable to identify the protective alleles associated with virologic control in elite controllers such as HLA-B27 and B57. There's no state of CCR5 delta heterozygosity, as was discussed earlier by Rich D'Aquila. And importantly, that this child does belong to this mother. This really is a mother-infant pair. As you can see, they share HLA alleles. Now, follow-up testing on looking for HIV-specific immune responses, again, as a marker of exposure to the virus, and even looking for the effects of these immune responses as an explanation for the outcome in this infant. We failed to detect. These studies were done in Dr. Catherine Laduriaga's laboratory. We failed to detect any HIV-specific antibody or cellular immune responses. And so from this case, we can clearly say that this is a single case. Like Mr. Brown, it's a single case of very early treatment leading to sustained remission with no detectable replication competent reservoirs. But we do detect a genetic footprint of the virus that we need to really further confirm in an attempt through sequence analysis, which has been challenging. In terms of the way forward, in order to replicate this, there is a clinical trial that's planned, P1115, which Ellen Chadwick is the co-chair of, looking at very early treatment to achieve cure in children domestically and internationally. And then I really want to quickly end with two cases with an emerging theme here with respect to very early treatment and attenuation of virus spread and establishment of viral reservoir. This is a case we reported at CROI this year, known as the LA County baby, who's a second infant that's been treated as early as 4 hours of age with AZT, 3TC, nevirapine, that was then switched to a PI-based regimen, in which you can see 2 nucleic acid tests are positive at 4 hours of age and 36 hours of life. And even when the viral load became undetectable on day of life 6 to less than 20 copies, a spinal tap that was done for other reasons shows persistence of viral RNA in the CSF at a level of 32 copies per ml. But what's notable about this child, and we haven't really seen this early, where evidence of HIV infection it becomes very hard to detect HIV-infected cells in this child, and you could see by 6 days of age, the viral load has become undetectable and has stayed undetectable through nearly 10 months of age. Proviral DNA assays have become undetectable, as is replication-competent reservoirs. But this child remains on antiretroviral treatment. This is distinct from the Mississippi child who's off treatment and is in clear remission. What we're saying here is that very early treatment may modify the pathogenesis of virus spread and establishment of reservoirs. And I want to end with this case in adults because I discussed that there are multiple factors that could have contributed to the Mississippi child, not only the very early treatment, but the immaturity of the immune or the naivety of the immune system. But here's a case, an adult case, very similar to the LA case that I just described of an HIV adult who was enrolled in a PrEP trial and had 2 pre-trial enrollment samples that showed no evidence of HIV infection, was started in the PrEP trial with Truvada. And what you see here is the baseline values came back positive for HIV RNA. So this patient was identified as being HIV infected while under the cover of PrEP. And again, this RNA was positive before PrEP was administered, and antibody testing has been negative. But in this patient, based on the viral load of 200 copies, ART was initiated, and I think it was an intensive heart regimen has been initiated. And what you see here, repeat plasma viral load at 7 days on after PrEP initiation was low, but still detectable at 120 copies per ml. And all other tests have remained negative for HIV in this patient, including looking at specialized subsets of memory T cells that Asier will discuss later in the VISCONTI cohort, showing no evidence of proviral DNA in this patient. And at nearly 6 months on antiretroviral treatment, culturing, I think, 60 million cells, they've been unable to recover a replication-competent reservoir. This patient is CCR5 wild type and has no protective HLA alleles to explain this outcome. So in my mind, this represents an emerging theme that perhaps across the spectrum of pediatrics and adults, if we can identify infection early enough under coverage of prophylaxis, that there's some individuals who may be able to achieve a cure. Now, the only way we can tell this is if these patients go off antiretroviral treatment, and that's a whole topic of discussion for this afternoon in terms of the ethics of treatment cessation. But there is a plan to stop therapy in these patients at 12 months of age. So to conclude, I'll say that these cases provide some optimism, at least in terms of one approach with respect to very early therapy to prevent HIV from establishing its foothold in the immune system of infected persons, and to really result in perhaps a pathway towards HIV remission or cure. I'll stop here and acknowledge the 2 individuals who spearheaded the Mississippi case, Dr. Hannah Gay and Dr. Catherine Luzuriaga, who is the immunologist involved in these cases. And the bottom left, the people in my laboratory who worked very hard to characterize HIV reservoirs in children, and our collaborators in the LA County cases, Dr. Audrey DeFecas, and of course the funding agencies, without whom this would not be possible, and to Mr. Brown for really changing the field of HIV therapeutics. Thank you.
Thanks. Please write down your questions. I know I have quite a few, but we're going to have questions after the next speaker. I'm going to ask Dr. Asier Sáez-Cirión from the Institut Pasteur in Paris to talk to us about adults, and he has been a leader in this field with the landmark VISCONTI study that again establishes a really interesting idea of early treatment. Thank you very much for being here.
Thank you, Rich, and thank you for the invitation. It's a pleasure to be here and being able to discuss our study with you. So I will be presenting the data from the VISCONTI study and some recent data also coming from a clinical trial, the OptiPrim clinical trial that has been just recently finished in France, with some insights that could be helpful to the VISCONTI and the remission of HIV infection through early treatment initiation. And unfortunately, I won't be able to tell you why the VISCONTI patients are VISCONTI patients, because we still don't know how they manage to control the virus. We were initially interested in this group of elite controllers that Rich and Deborah talked before. So very rare patients who are able to control the virus to undetectable levels in the absence of treatment. And as they say, they are a great model of what we could expect if remission of infection could be achieved in all patients. In the last few years, we have made very important advances in understanding the mechanisms contributing to control of infection in these patients, and I think that there are more or less consensus on all the different teams working with these patients that are probably something going on during the primary phase of infection in these individuals, either infection with some attenuated viruses, the role of intrinsic thought restriction, and also the role of innate responses that are going to reduce somewhat the dynamics of viral replication during primary infection, and this is probably going to help to induce an optimal response against HIV, and this contributes later to establish this control of infection in the long term. And actually, there is something that is very clearly associated with natural control of infection, is the presence of some protective HLA class 1 alleles, and in the court in France, we are following more than 200 elite controllers in our court, and only 80% of these controllers carry one protective HLA class 1 allele when compared to the reference population in France, and also to the NRS Primo cohort of patients infected in primary infection. You can see this very clear overrepresentation of some HLA class 1 alleles. And related to that, we were able to show that the CD8 cells from these HIV controllers were really efficient in identifying and eliminating very efficiently infected CD40 cells. So this is HIV replication in vitro in CD40 cells from HIV controllers. And this is what happens when the CD8 cells from these patients are present in the culture. And here we are showing up to 4 log drop in the production of the virus in the presence of the CD8 cells from these individuals. So this gave some clues about what the CD8 cell response, a protective or an effective CD8 cell response may consist of. And it has boosted interest in developing CD8 cell-based vaccines. But the question that we were asking all the time when studying these individuals was whether we will be able to induce this phenotype in other patients that didn't share the same genetic background than the HIV controllers. And this is how the VISCONTI study was born. We were looking for individuals looking like HIV controllers, but not being HIV controllers. And we were lucky to have among our collaborators Laurent Oclou, Thierry Prasuk from the Orléans Hospital, who told us that they have observed that some of the patients that they have treated very early during primary infection in the hospital, and then after a few years have interrupted treatment, were able to keep controlling the infection in the long term. And we found that observation extremely interesting, so we retrospectively went looking for more of these patients, and initially we identified 14 patients in which we observed that the common characteristic, and we were not looking for this precisely, but this was a common characteristic. In the 14 patients, the treatment has been initiated very early during primary infection, within 10 weeks of primary infection and in a median of 39 days following the date of infection, of calculated infection, or presumed infection, sorry. And then they have been treated for a median of 3 years and interrupt the treatment, and then they were controlling for a median of almost 8 years in the absence of treatment. And you can see that in some cases, there were some blips of viral load just after treatment interruption, but in most cases, the viral loads were completely undetectable for many, many years after treatment interruption. And I will show you a little bit later the actual status of the VISCONTI cohort with new data on the follow-up of these patients. So at the beginning, we thought, okay, we are observing these individuals, but which is the frequency of this phenomenon? And moreover, how can we be sure that these people were not going to control infection spontaneously, like the elite controller that we were studying in our other cohort? So first, we have epidemiological data from the HIV controller, natural HIV controller cohort, showing us that among 34,000 patients followed in French clinical centers, we have been able only to identify initially 81 HIV controllers, and making a frequency of this phenomenon to be 0.24%. And starting with the observation from Logano Clou, Thierry Prasuk, and the Orléans Hospital with much lower number of patients, they have estimated that up to 15% of the patients that they treated during primary infection and for long periods of time were able to control infection after treatment interruption. We made similar analysis with people in the NRS Primo cohort and found out that the frequency in this cohort was of 8.5% of individuals treated during primary infection, being able to control after interrupting the treatment. We wanted to have some more insight, so we interrogated the French database, the French hospital database on HIV-infected patients. This is the largest database in France on HIV patients, and we choose a window of opportunity for treatment initiation of 6 months. Actually, we don't have any clue whether this is the good window, but making the estimations during the epidemiological analysis, this seems to be the best, but a lot of work needs to be done to address this question about the window of opportunity. But in any case, interrogating this database, we observed that among patients who were identifying primary infection, treated within 6 months of infection and for more than a year, and 15% of these individuals were able to control the viral load for at least 24 months. And so the frequency was huge, and we were really surprised not having found these individuals much more easily. So we came back to our analysis and found out that obviously this frequency of post-treatment control is very big. But to arrive there, we have to screen a lot of patients who have been treated. I mean, we start with 3,500 patients identifying primary infection. From those, only 1,000 start treatment during the 6-month window period, and only 656 keep the treatment for at least 1 year. And among those, just 1/10 of the patients stop the treatment. So the post-treatment control phenomenon is frequent among those following the steps that we have identified, but is rare because the procedure was not commonly used in France, at least. So we continue comparing our post-treatment controllers to the natural controllers that we were studying in our cohort. And we have the chance to follow some of these individuals from the primary infection, even patients who were going to become natural controllers. And we compare them to the patients who will become post-treatment controllers. And as you can see in this figure, the patients who are going to control naturally the infection, they start this control very early. During primary infection, they have already much higher CD4 T-cell levels than patients who won't control infection, and they have also lower viral loads than patients who won't control infection. In contrast, our post-treatment controllers are completely undistinguishable from patients who usually don't control infection in the absence of treatment. Another difference is that our post-treatment controllers were very symptomatic during primary infection, and the natural controllers were not. obviously the most clear characteristic associated to natural control, as I say, is the MHC background. And you can see again here the profile of the natural controllers in our court in France, and the comparison to the reference population in France. And you can observe again the overrepresentation of HLA-B27 and B57, and at the same time the exclusion of some other HLA class 1 alleles, B07 and B35, that has been associated with higher viral loads. And again, this is the CD8 T cell response in the natural controllers with much higher capacity of the cells to eliminate infected CD4 T cells. And when we compare this to the post-treatment controllers that we were studying, you can see that the picture of the MHC is completely the opposite to the natural controller. We don't have an overrepresentation of HLA-B57 and B27, and we have a very strong presence of HLA-B35 and B07, and in particular the B35 is something that is quite intriguing because it keeps coming with new inclusions in the course. So we are really surprised to see these B35 patients being able to control infection in the absence of treatment. And because probably of this non-so-favorable MHC background, the CD8 T cell response in the post-treatment controllers is really weak, both in terms, like shown here, capacity to eliminate infected cells, but also in the frequency of cells able to produce different cytokines. And in some of them, we are unable to identify HIV-specific CD8 T cell responses. We have recently analyzed the the HIV-specific CD4 T cell response. Here, the things are a little bit different, but in any case, the frequency of these cells is extremely weak. In some patients, we don't detect any HIV-specific CD4 T cells, but overall, it seems that the frequency may be a little bit higher than what we observe in elite controllers. And moreover, we found some kind of polyfunctionality of these cells in some of the post-treatment controllers, with cells able to produce a few cytokines after stimulation with peptides. The differences are marginal when compared to elite controllers, but this is something that we need to look more carefully. And we are not just sure how this is contributing to control of infection. And in any case, the differences are not much. They are not very important when compared to other patients who were treated during the primary phase of infection. There is another difference between the natural controllers and the post-treatment controllers, and this is the level of T cell activation. Natural controllers, they have higher levels of T cell activation than normal donors or treated patients. And this is very clearly shown with the expression of HLA-DR on CD8 T cells, like shown here. In the case of post-treatment controllers, we don't see this increase in activation markers on T cells, and we are actually looking right now to other activation and inflammation soluble markers to confirm this data. There is something that was quite intriguing when we were looking to the data on our HIV controllers and on our post-treatment controllers. As I say, in some of them we were lucky to have data following them from the primary infection, and we could follow actually the number of cells carrying HIV DNA during primary infection. You can see that there is a very nice decrease of the number of cells carrying HIV DNA with treatment. That is not surprising. But we observe also a tendency to decrease levels of cells carrying HIV DNA after treatment interruption. We have data only for 8 patients sequentially, and in 5 of them we could confirm that the HIV DNA was decreasing over time after treatment interruption. In the 3 others, it remained in 1, it remained stable. In the 2 others, it was going down, but then they make some blips of viral load and the HIV DNA increase a little bit, but they still keep controlling infection afterwards. So how these patients manage to have these very low reservoirs, and why these reservoirs may be going down even in the absence of treatment. We first checked whether we could isolate virus from the cells from these individuals, and we were able to isolate HIV and to detect the replicative virus from the cells from all of these post-treatment controllers. So clearly there is no eradication of infection. These guys are infected, and this is why we call we say that they are in remission of infection. The virus is still there, and we cannot exclude that sometime they will need to restart treatment in a few years. But so far they have been living without treatment and doing very well. But in any case, we could isolate virus from all the different T cell subsets, including naive T cells, from all these individuals. And we have been able to assess the replicative capacity of this virus from at least some of the individuals in vitro. We are sequencing the virus, so I don't have data about the sequence of the virus so far. But in vitro, the virus are doing really well. And showing 3 different viruses from 3 different patients. And these are compared to reference values from other primary isolates that we have in the lab. So this is infection of CD40 cells from healthy donors. And the viruses are doing really well. We have checked also the susceptibility of CD40 cells and macrophages from these individuals to infection, and they seem to be, obviously, like always, is a little bit heterogeneous among the patients, but there doesn't appear to be any kind of very strong restriction of viral replication in these patients. And I will say that this is not very surprising, because during the primary infection, these individuals have very high viral loads. Actually, we have the 2 cases with the highest viral load in the NRS primo cohort became VISCONTI patients. So we don't expect the virus of these patients to have any special characteristic, or even the cells being particularly resistant to infection. We were able also to describe how the reservoir was distributed in the different CD40 cell subsets. As you may know, it's thought that most of the reservoir, the persistent reservoir, is established in the central memory and transitional memory T cell subsets. In the case of this is actually what we found in the natural controllers. This is the contribution of the subsets to the reservoir. In the case of the post-treatment controllers, we have a biased distribution with a more important contribution of transitional memory T cells to the reservoir. And this is not due to a protection of central memory cells from infection, but to a higher frequency of transitional memory cells circulating in these individuals. So there is a biased distribution that was established during primary infection, and we believe that probably T cell homeostasis is playing some role in this phenomenon of control of treatment or after treatment interruption. But in any case, the fact that there are these transitional memory cells that are shorter lived than central memory cells contributing the most to the viral reservoir may perhaps explain why we are losing some infected cells over time in the absence of treatment. So this is the actual aspect of the VISCONTI cohort. We have 20 patients officially included in the cohort right now. We have 5 other cases in the pre-inclusion process, including 2 pediatric cases of 2 girls who were treated for 7 and 10 years and now being controlling for actually 7 and 10 years after treatment interruption, or 10 and 7 years, sorry. From the 20 patients that are officially included in the cohort, you can observe that the characteristics are roughly the same as the initial 14. So low CD40 cells during primary infection, and very nice reconstitution with treatment. This is an interesting characteristic in most of our post-treatment controllers. The reconstitution seems to be very fast and very efficient. And then stable CD40 cell levels after treatment interruption, and obviously control of viral load after treatment interruption. So the median follow-up for all of our patients is close to 10 years now of the treatment interruption and viral control after treatment interruption. Median age of our patients is 48 year old. We haven't had any single case of AIDS event. There is 1 patient who started an antiretroviral treatment associated to a cancer, and the viral load was controlled during before treatment resumption, and the cancer is in remission. It has been in remission for 2 years. We haven't had any case of treatment resumption linked to viral replication, and for more than 300 viral load determinations, most of them, as you can see, were below 50 copies. We have had some blips including a few cases of blips above 400. Most of these blips above 400 were during the very early periods after treatment interruption. But in any case, even in those patients in which the viral loads went up to 200, 300 copies, they have been able to maintain control of infection at these relatively low levels for many years now. So we have many differences between the natural controllers and the post-treatment controllers, and this makes us to believe that the early treatment initiation is actually a very good way to induce this remission of infection in at least some patients that are not able to were not expected to control infection spontaneously. And I won't be entering into the difference because this is things that I already presented. But how this early treatment may be contributing to that? We know that early treatment is limiting the establishment of the viral reservoir. This is quite clear, and Deborah showed us some data even in the children. The early treatment is limiting also viral diversity, is reducing immune activation, and also is protecting the whole immune responses, all the effectors of the immune responses. And probably there is a contribution of a combination of all these aspects contributing to control of infection in our post-treatment controllers. Also, as you know, treatment is prevention. And in France, we are trying to implement the test and treat very early because we are convinced that there are individual and global benefits. But here are some data from France, not very different, I think, from what was shown before in the Chicago area. 25% of HIV-infected persons in France had not been diagnosed, and actually we estimate that they are responsible for 60% of new contaminations. And also these patients are late diagnosed, and so we want to implement a new test, very rapid test and immediate treatment initiation. And just very quickly, two data coming from the OptiPrim clinical trial. In the OptiPrim clinical trial, we treated patients in primary infection for 2 years with a 3-therapy or a pentatherapy, including maraviroc and raltegravir. The idea was to see whether there was some major impact in the viral reservoir after 2 years of treatment, and then propose a treatment interruption in the patients and see whether there could be some control of infection after treatment interruption. So I won't present the main data from the OptiPrim clinical trial that was presented in CROI, but there is something that we were doing in parallel with the OptiPrim and the VISCONTI study, and was to compare the levels of viral reservoir in patients from the OptiPrim clinical trial, from the VISCONTI study, and from another group in the VISCONTI study that we call VISCONTI Group B. These are patients who were treated like the VISCONTI patients for many years, starting in primary infection. And what you can see here is that even if we managed to reduce a lot the viral reservoir in patients in the OptiPrim clinical trial, the levels of viral reservoir in all the T-cell subsets that we analyzed was still much higher than the levels of viral reservoir in the VISCONTI study, here in white, and also much higher than the individuals in the VISCONTI Group B patients. These patients had been treated for a median of 6 years, starting in primary infection. So the message here is that even if we reduce the viral reservoir, 2 years of treatment initiated in primary infection was not enough to reach the levels of viral reservoir that we observe in the VISCONTI patients. And the much longer treatment are necessary to arrive there. So this is the last slide. We proposed to the 90 patients in the OptiPrim clinical trial to interrupt the treatment after 2 years. 1/3 did not accept this treatment interruption. 2/3 accept the treatment interruption, and from these 63 patients, 4 maintain viral loads below 400 copies at M30, so 6 months after treatment interruption. This was the endpoint of the study. And at that time, 2 patients resumed treatment, even when their viral loads were below 100 copies. They were proposed by their treating clinicians to did so. But there are 2 other patients who have been off treatment for more than 1 year now, coming from the court. I like to show this because it's very, it summarizes what we are observing in the VISCONTI study. And in the first case, we have this patient who made a huge blip, more than a blip, because the viral load went up to 20,000 copies after treatment interruption. And then he was able to manage to control infection to very low levels, and has been controlling infection for a year now. On the other case, we have this other patient who never lost control of infection, and that actually is again an HLA-B35, and keeping a perfectly controlled viral load for 1.5 years right now. And the thing that is, I think, a very important question is, if you see this kind of loss of control, how reasonable is to wait for these people to control? Because obviously there is, with partial loss of viral control, we haven't seen many differences in the clinical aspects, but there is clearly a risk of transmission of infection in this individual. So I will just finish there with this kind of thought about the difficulties of addressing the treatment interruption, and I just want you to remember that we are launching an international VISCONTI court, and if you want to contribute or you have questions or whatever, you can contact us at visconti@nrs.fr. And finishing with the acknowledgement, obviously first to the patients and the clinicians who follow these patients, who are critical for the study, and also to Christine Roussiou and Logan Oclou, with whom I have coordinated this VISCONTI study. Thank you.
Thank you very much. And I'd like to ask Dr. Persaud to come up too. It's a little awkward, but I'll ask Dr. Persaud and Dr. Sáez-Cirión to stay with the podium. And Ellen, why don't you come with me? We'll use the handheld here. Okay. So the floor is open. The microphone on that side of the room is the only one to use if you want to ask questions. Please go around to where Dr. Hope has the first question.
Deborah, I know you showed sort of the, there's nothing obvious in terms of some of the genetic components, but have you ever done an experiment where you can take, like the virus maybe derived from the mother or for some of those early samples, and then see if the virus will grow in the PBMCs of the Mississippi baby?
So what we've done, that's a good question, but what we've done is characterize maternal isolates to actually confirm that it's a replication efficient isolates. Now, obviously, when we first got involved in the case, the child was 23 months of age. At presentation, the viral load was 2,400 copies in the mother, but at 2 years later, it's about 6,000 copies, so not dramatically different. And we've been able to recover at least 20 replication competent isolates from maternal samples, of which all are comparable with respect to laboratory strain 3B in the replication kinetics. But we haven't done the experiment of then superinfecting the infant's CD4 cells. I mean, we've largely focused on trying to recover virus from the infant. The evidence with respect to at least replication in the infant is supported by, initial viremia, persistent viremia over the course of treatment. But certainly, I mean, I think that would be an important experiment to look at whether there's cellular factors that may have contributed to addition in that infant. I think one way, and it's why I presented the second case. I know there's, again, a lot of controversy surrounding presenting the second case, but I think if we start to see, even in terms of the dynamics of infection can be curtailed just with treatment alone across the spectrum, and in light of the adult patients too, I think there may be, it supports that the early treatment has a major role in this, but certainly cellular factors could play a role.
Right, just very quickly, because there's some papers that are probably over a decade now where they took a bunch of different virus isolates and one person's PBMCs and showed a huge variation, thinking log differences in their ability to grow. Mm-hmm. And then the other experiment was to take one viral isolate and a bunch of different people's PBMCs, and again, you had several logs of difference in the ability of the virus to grow there. And that could just maybe provide some insights into the mechanism.
Yeah, no, that's a good idea, Tom. You always have good ideas. I know him up from Maryland.
Yeah, thanks for those two really excellent talks. The first question is for Dr. Persaud and Ellen. I'm just curious to know the design of the NIH study that you talked about, because from all that we know now about early treatment, how would you be able to, basically would it be a randomized trial in which you will treat some kids early and not treat others? And the second question is for the Visconti presenter. Now that we are hopeful that a cure will come for HIV, we don't know when, I'm curious to know your thoughts about the impact of treatment interruption on the reservoir of individuals. So when we interrupt treatment and patients achieve remission, during that interval, could they repopulate reservoirs or expand their reservoirs so as to then make them more difficult to cure in the future if such became available?
I mean, I could comment quickly on the trial, and Ellen could expand. But so the P1115 trial that's planned, it's not a randomized control trial. It's actually enrolling kids at high risk, like the Mississippi baby, and starting them empirically on a 3-drug regimen while awaiting test results, nucleic acid test to confirm infection, and those who are identified as infected will then continue treatment. It's actually a very difficult trial to do because, you know, our first goal is to prevent infection, not to treat towards cure. And so it actually requires enrolling over 400 women to get 20 evaluable infants for that first cohort study.
Yeah, so the question was about the evolution of the reservoir during treatment interruption periods. Yeah, this is an important question and something that we are evaluating in the context of the TPRIM clinical trial, actually, because it's a structured protocol. And the preliminary data suggests that there are not major impact in the levels of viral reservoir during this period of viral interruption, because in most cases the treatment period was, the interruption period was extremely short. Whenever there was some positive viral load, treatment was reinitiated immediately. There were some cases like the one that I presented in which for different reasons the treatment was delayed, and actually because the viral loads were going down so quickly, the clinicians decided to wait a little bit more. And in these patients, for instance, the viral reservoir was extremely weak. So no major impact if this follow-up is done. I mean, if a very close follow-up is done during this period of time and there is a quick reaction to loss of viral loads. It means that probably we will be losing some cases of people able to control this escape of the virus, but my actual opinion is that we cannot take the risk not to treat these people immediately.
Thank you. My question is about the VISCONTI study. You partially answered a question I was going to ask, so I'm going to modify it, regarding the optimal timing after infection within which to initiate therapy to essentially induce post-treatment control. Yeah. And you said that you thought 3 months was around the time. Well, most of us don't have the luxury necessarily of encountering people within 3 months of infection. But nevertheless, was there any evidence from your data that among persons who were caught or who were identified substantially sooner than 3 months after infection, that there was a greater likelihood of therapy initiation resulting in post-treatment control, meaning that was within that 3-month period, was 1 month better than 2 months better than 3 months? Mm-hmm.
Yeah, the data that we have is not big enough to make this kind of conclusion, but it's true that when we look at with Laurent Nucleu to the data that they have in the hospital, and this is a very small data set, there was some relationship between the ratio of immediateness of treatment and the length of the treatment. I mean, people who were treated the earliest and the longest were the ones who were able to control infection in this small subset of individuals. But then I think that we have the opportunity now to learn a little bit more from the studies coming from the Thailand court and other court in South Africa, with people being diagnosed extremely early during FIVIC 1 and 2 and initiated treatment at this period of time. And they have already found out that the decrease in the viral reservoir is much more important in these individuals than in those that we were able to identify that were FIVIC 3, 4, 5. So perhaps these individuals will have a better chance to control after treatment interruption, but this is something that we don't know. We have also data from also looking retrospectively to monkey studies, showing that in immediate treatment, I mean starting a few hours after treatment, after viral inoculation, was not associated with post-treatment control of infection. And actually a treatment initiated a few days after that, it was associated with post-treatment control of infection. So that means that perhaps we need still some immunity, some immune responses that need to be boosted at the very beginning and then preserved, and this is what is helping these individuals to control infection. But this is just speculative.
In an effort to try to get back on schedule, please keep your questions short. Thanks.
Dr. Sáez-Cirión, you didn't have favorable Class 1 HLA. Did you look for favorable Class 2 HLA? And the hypothesis would be that the having such a favorable class 2 gene would allow you to recognize antigens at a much lower level than someone who didn't.
Yeah, we haven't looked yet to the HLA class 2 alleles. We are doing this right now because we are conducting a whole analysis of many genetic parameters in these individuals. And so perhaps there is some it's clear that there are some differences in the levels of the CD4 T cell responses in some of these individuals, not in all of them. In many of them, the responses were still undetectable. But this is something that we are looking at because we have also some data from natural controllers with no CD8 T cell responses, and again, the CD4 T cell response seems to be higher and strong, so we believe that we need to look at these responses more carefully.
My question is about the virus. So in these studies, has any viral dynamics populations studies or study of how the virus is evolving in these patients rather than, more than just check if the virus are viable or not, but how the diversity, dynamics of those populations are behaving in both studies?
So I can comment on the pediatric population. What we see 16 years later in those you can recover virus, it's completely identical to the initial infecting strain, so in support of a long-lived population of cells.
What I can say from the VISCONTI study is that the initial data we are doing ultra-deep sequencing of the virus, so we don't have data of the whole sequence, but we have some data from the diversity. In all patients, in any case treated in primary infection, the diversity is very reduced, and in the case of the VISCONTI study, it's the same. There is virtually no diversity of the virus that we have identified.
My question is for Dr. Persaud. I'm wondering who makes the decision of whether the LA baby goes off the medication?
Yeah, that's a very good question. So it's going to be a discussion with the local IRB, the care provider of the patient, and the physician of the families to decide whether that child should go off treatment. It's definitely, actually, I think it's a whole topic of discussion in terms of when to stop therapy and who can stop therapy. And maybe the adult patient will go off therapy before our child reaches age. And so for the treatment, early treatment trial, we have built into that treatment interruption at 2 years of age. And, there were trials in South Africa in infants starting therapy early where treatment was stopped at 40 weeks and then 96 weeks of age. So there's a fair amount of experience with treatment cessation in pediatric populations, and with close follow-up, it can be done safely, but the field really has been colored by the SMART trial, and so it will be a joint discussion. I'd be interested in your thoughts on that.
Thank you.
Well, I'd like to thank our speakers for some very stimulating talks and for a robust discussion. We'll take a 5-minute break, and if everyone could